introduction, and thanks to the IHPBA for asking me to speak about this very common problem about fat in the liver. So what I will do during the next 20 minutes is to try to go to these four topics, give a little bit background about liver steatosis, then we'll speak about what that means in the donor and what that means also in the recipient. So number one, steatosis is a frequent condition. Whether we can call that a disease, it may be questionable, but it's frequent. 30%, a third of the Western adult present with hepatic steatosis. Those who underwent resection, again, 30% have some degree of steatosis, cadaveric graft the same, and in living donation, this is an issue when we find some fat, and this is at least in Western program, about 20% of the population that, despite all the screen, present with some steatosis. Now, we have a problem of organ shortage, so meaning that we have to look for organ that we've not used before, but that could have good result. We focus on this condition here, the non-heart beating donor, the graft that are from older patient, donor been long time in the ICU. But probably the biggest member of this family are graft which contain some degree of steatosis. So where comes the steatosis? There's many different factors that affect the liver and can cause steatosis with or without inflammation. The main cause of steatosis, at least in Western countries, is obesity, and you can see in this cartoon there's a number of problems here, the global warming, but at least for the United States and others, the number one problem might well be obesity and related diseases to obesity. Now, the other thing is increasing everywhere in the world. There is an increase in liver steatosis, or in obesity at least. And you can see here, whether it's female, whether it's male, whether you could hear in South Asia, East Asia, there is a dramatic increase, 2 or 3 times more when you compare 2008 and 15 years before, with the highest incidence in North America, but also in Southern Africa and other countries. So clearly, this is an increasing and serious health problems worldwide. Now, what is this hepatic steatosis? And I summarize that this is really a wide range of clinically relevant diseases, and it's also responsible associated with complication after liver surgery and liver transplantation. But there is still today, and this is a debate, and looking at the number of papers that still exist on this topic, what is the cutoff, what is the bad steatosis, the one we need to be worried about, and the one that we may just ignore. So that's what I will try to cover here, is the assessment of steatosis, how we assess that, the impact of steatosis on outcome, and then discussing about some strategy to prevent or to cure steatosis in patients, for example, waiting to give a half of the liver for living donation. So assessment of steatosis, well, the first one, and many surgeons are learned to do that, they look at the liver to see how it looks like, and many centers will decide based on their experience with the liver, the fatty liver, look like butter, not or to use it, or to use it. If you look at the data from the UNOS in terms of the statistic of the organ use, you can see that about half, is even higher, 40%, have some degree of mild steatosis, less than 30% of fat in the hepatocyte, but there is also in 5 to 7% steatosis up to 30 to 50% or more than 50%. Unfortunately, this data is very questionable because most of the liver available in the United States, but also in database in Europe, they do not have any biopsy. So we are missing this information in large database. And if we look at the surgeon, there's been some study done to see, well, we are not as good as we believe, surgeon. It's about 60% of sensitivity. It's clear if it's a macrosteatosis of 80%, the sensitivity is higher, but the judgment of the surgeon or experienced surgeon is not as good as we think it could be. Now, traditionally and still today, we differentiate 3 types of steatosis, the mild one, which is less than 30%, which means that 30% of the hepatocyte contain some fat. Then the moderate, 30 to 60%, and more than 60%, the severe one. This is a quite accepted and established way of looking at steatosis and to report steatosis. Now there is not just the quantity, but now the type of the morphology, and here typically there is two steatosis, the one with very small microsteatosis, which is a small droplet of fat in the hepatocyte who does not, what we say, move the nucleus on the side of the cell, and you have on the right side the macrosteatosis, the one which is more easy to detect in some way. Now, what we do, so we learn from the biopsy. So I just want to, whether we need or not a biopsy in these patients, and what we learn, I think it's important. We don't just learn macrosteatosis. We also learn whether there is inflammation, which clearly add to the risk of using this liver, and we can also learn whether there is fibrosis or not, and there is an ongoing discussion, for example, whether we need to biopsy patients who are candidates for living-related donation. And my center, we do it routinely because it's not just steatosis, but we want to look at other findings in this liver. So is that a work that my group did a few years ago, and that was a bit to see whether we were accurate, or the pathologist is accurate in telling you whether or not the liver has steatosis on a biopsy. And here we took 4 very well-known pathologists who have all published in the field of liver disease, so they are experts in liver disease for 4 different countries, and we blindly show them a number of slides and ask them to judge what they think about the type of steatosis and the quantity. We have here an example. You have here a pathologist that we go for the pathologist 1, pathologist 2 here, and we see here that's whether they rank that, and that was the number of samples, and here, in this example, there was no correlation. So meaning absolutely no agreement between one pathologist and the other one. And here you can see there is Valérie Paradis from Beaujon, very well known here, Marie-Kay Washington from Nashville, Laura Rubien-Brown from Geneva. So all these pathologists were really experts in that. So here is the result at the end to detect significant, and we'll see later, steatosis, more than 30%. So the one we may worry about, I mean, if we look at the sample, one pathologist identified that in only 22% or the biopsy, and the same sample of biopsy, another one identified that in 46%. And there was not always even overlap between these cases, so showing that there is quite significant disagreement. And if we go to something that we may believe it's easy, what called lobular inflammation, one pathologist says 0, and another one found in half of the sample. And then even steatohepatitis, that it's something we all know, there was also very significant disagreement. One pathologist says 0%, and another one found that in a quarter of the same sample. So clearly here there was a very significant variation in detecting macrosteatosis, microsteatosis, and it was of course more predominant for the mild one than the one with 80%. So the idea here is to move to other gold standard. Maybe pathology is no longer the gold standard in this setting, and there's been some work done on computer. Today, even though there is a very nice program, there is still a lot of mistake, and I don't think there is any program that will use the computer. We have used that in the lab to quantify some of the fat, but this is not something that is clinically used. On the other hand, the MRI today, some study have been done showing that may well be the best way to assess steatosis in the liver. It could be difficult in some clinical situation, but for living donors and other patients, I think the MRI could well be the best way to assess steatosis in these patients. But again, if it is a low quantity of fat in the liver, then the accuracy is less. Well, now, I mean, we are clinicians, whether we are a hepatologist or surgeon, we want to know whether that has an impact or not on the patient that we are treating. Let's go back here to some work in the laboratory here. It was done several years ago. This is simple experiment, ischemia reperfusion in a lean, and that's done after reperfusion. So in a lean rat here, you can see basically, if you give you, I think, 30-minute warm ischemia and reperfuse, there's not much changes, a few leukocytes. But if you go in a fatty liver, then you can see dramatic changes with infiltration and necrosis in this liver. So no doubt here that if you have a fatty liver, here that's what the Zucker rats, so they have a significant amount of fat, there is a dramatic increase injury after ischemia reperfusion injury in animal and of course also in human. Now if we look at a little bit more at different mechanisms, one way is to look at the microcirculation. Fat affect microcirculation. So here, this is also experiment that have been done here, no steatosis, and you can see that's the normal liver, and here's a very nice sinusoids that we can see using the intravitreal microscopy. If we take the microsteatosis, the small one steatosis, you can see here there is a difference, but you have here still narrow, but still a fair number of sinusoid in this liver. On the other hand, if you go here to significant or severe macrosteatosis, you can see that even in the normal liver, there is dramatic changes in the sinusoid due to several factors like ballooning of the hepatocyte. So clearly, there is a dramatic increase of injury that will happen if we do any stress on this liver, since the baseline is very different among these three types of liver. And there is other factor, the ballooning, which affect, we explain in part, not only there is other mechanisms involved in the reduced flow in the sinusoid. You have also, in terms of the metabolism, you have less production of ATP, so less possibility to recover from different type of injury. And there is some physical property associated with the lipid, which may alter even the plasma fluidity and cause some thrombosis in the sinusoid. So I will not here just showing that to go to all these studies here, but basically this is different studies that look, and you can see there's a lot of variation here at liver steatosis and outcome after transplantation in human. And basically here, there is a lot of variation. And you can read this paper. We have done our group to look at that. And we see that it varies between 0%, when their papers say there is absolutely no impact, and others will come and say it failed basically all the time. So it's very difficult here looking at this data to really conclude what is important or not in this series. And here I will just show you one study that we did looking here at severe steatosis, not the mild one, but the severe one. And we took here 60 patients with liver transplantation, 40 patients have less than 10% steatosis, and 20 here have more than 60%. We don't do this transplant very often because these liver are often rejected. But here with the shortage of organ we have in Switzerland, with basically 30 to 40% at that time mortality on the waiting list, when we could offer this organ to low-risk patients, I will show this data later, we decided to use this organ. So here I will also don't be afraid about this slide. It's just comparing here the control group, the 40 versus the 20%, and just what we can see and to be expected if we look at the transaminase, the delay function, not the primary non-function, the incidence of renal failure, ICU, etc. Clearly, the recipient to receive this very fatty liver had changes. And we have also, during surgery, increased blood loss, transfusion, etc. So clearly they were not doing as well. But very interestingly, in this, we have no difference in graft survival. And we also observed that the fat go away relatively quickly. Within 2 weeks, we did protocol biopsy, and the fat was almost gone in all of this organ. So the question here that comes from this study is, okay, it worked. I mean, now how to use this organ? I think we cannot go from this retrospective study, say use it in any recipient, and that triggered another study from our group. We watched to look at the matching the donor or high-risk donor or normal donor with the recipient. I think this is today a very important and hot topic in liver transplantation. So we know that there is donor risk, and every time we're doing transplant, we heard this kind of story. We ask this question because this is added risk, and we have the recipient that we also have a very different recipient. Here you could have extended graft, extended criteria donor here, with, for example, a fatty liver, 80% qualify for that, non-heart beating donor, and the recipient. We see more and more today, because we have also a MELD, so the organ go to the sickest patient, very sick in the intensive care unit. And the question here is which organ to whom to do it with justice and fairness. And here I would just present a work that was done by one of my transplant surgeons, Dr. Dudkovsky, review all the data from the UNOS and test that in the data in Europe, and he identified these factors here that are all, in fact, well known in multivariate analysis, and with a statistician did a score system. I will not go in detail how that, but you can see here the MELD, so the condition of the patient, whether it's a retransplant or not, whether the patient is intubated in the ICU. We put that because this data is available in the UNOS. The cold ischemic time and the donor age were the most significant factor. And then with a statistician did a formula weighting this different, and then you have a range between 0 and 27 points. So this is the match of a donor for a recipient. So in other words, the idea here, you have a patient, so you know your patient, you have a phone call, and we tell you that's donor, do you want that donor or not? And then we can calculate here with the points what is this balance of risk of using this organ in these specific patients. And this study, what it shows again is the UNOS database with a very large number of patients, 50,000 patients here. And that's the curve that we found, which is not available with other score systems. This is the 1-year mortality, so pretty relevant, and just the bar score that go up to 27. And very interestingly, this curve is very attractive here because it's not a linear curve. You can see very easily here that there is a good part here. All these scores do well. The 1-year mortality is less than 20%. And suddenly here, at point 18, there is a cutoff in this bar system, and here you have an increased mortality from this cutoff of 18 in this bar score. Now, this is, if we have this puzzle, that's the criteria we have on board. We did not put steatosis at the beginning because the data, as I mentioned before, is just not reliable in the UNOS database, but we combine now with the ELT and other data, and we wanted to see in this score whether the steatosis may affect the score, and we did some study looking at these factors. So what I would like to show you is the result here in 2 slides of this test. I think it's important. So we have the low risk, this is here, so the bar score 0 to 9. You have seen in the curve before, the bar score 0 to 9, very good combination for a donor and a recipient. Low risk, if we compare here the patient here who have 0 to 30% or more than 30% fat, there was no difference, absolutely no difference here in, again, the survival and the cumulative survival of the patient and the survival here. So we have here the score, we have no difference in these patients. And here we have a survival here at 5 years that basically 70% here in this patient. So very good result, and again the same whether we have fat or not. Now if we take the intermediate risk in this patient, so we have here a bar score that go from 9 to 18, so here the cutoff is at 18. Again here you can see whether they have less or more than 30% fat, no fat or fat, also no difference in this situation. And the high risk is the same also, meaning poor result here, whether or not you have fat, and we have seen that the mortality here is very high here at 5 years is less than 50% in this group. So basically, what we show here is that fat up to 30% has no effect on outcome here. Now we were interested in it's a very large number of patients, or those with macrosteatosis, and did the same test in this patient. And again, we take only macro here, 0 to 30 versus moderate or severe, more than 30%. And here you can see the two curves are not the same. If we take here even the low risk, there is already a difference between the normal liver versus the fatty liver. And if you take the intermediate, there is again here even a wider difference here of risk. And if we take the high risk, then this is very dismal. You can see here that's basically 0% survival at 5 years. But we also know that bar score more than 18 is not good for the normal liver. So now we have to decide about the threshold of was is acceptable or not. And here we can see here that at 5 years we still have a 60% survival. Even it's less than no fat, but it's still pretty good, bar 0 to 9. If we go the 9 to 11, here we can see we are lower than 50%. If we decide this is an acceptable cutoff, here we are less, and this one is of course very dismal in this situation. Here's the different survival at different points. We see here we're below than 50%, and here we're very bad in this. So clearly, when you have more than 30% macrosteatosis, this is a higher risk for a transplantation, and we may, in fact, just consider here this kind of organ. So I give you an example here to see what it means. So if you have here practically an offer, you have a patient who is in the ICU, 60 years of age, intubated, the MELD is 34, looks like a typical patient for us, never been transplanted before, phone call, an organ donor is 40 years of age, and we think the cold ischemia time, we can estimate that relatively well. It's about 7 hours, the cutoff. So we have a bar score of 15 in this case. So we do a biopsy, 40% macrosteatosis here, so we have to adjust here, bar of 14, 40% macrosteatosis in this liver. So normally what I say, we should not accept this organ. Survival will be poor. We go only to the bar score of 9. And here we have less than 50% 5-year survival. If we have the same scenario now, but the patient is not intubated in the ICU, and the MELD now is not 35, but is 20. So that's a big difference in the condition. We do the biopsy, again we have macrosteatosis. The bar score here is 7. And here, based on us, and we are using that on a routine, then we will use this organ for this specific patient. Here, just to go a little bit in the recipient, I think it was two or three slides with the recipient here, and you can see this is data from UCLA here, where they show, in fact, the total of transplant. The majority was for hepatitis C, but you can see here this curve here, which increased dramatically. This is the NASH. So NASH is becoming more and more a serious problem, and if you do a percent relative increase compared to all the other indications, this is the one we are the most worrisome, and now with the new approach for hepatitis C, it may well become number one cause for liver failure, so it increases our interest or the desire to know about the fatty liver. Now, if we look also at the NASH, there is the NASH or the NASH with high risk. This is patients who had NASH or have NASH with high risk, and this is the survival in years after, and the risk is defined here, patient on hemodialysis or high BMI, which is frequent in this patient, and you can see here that we can learn more about the NASH, and there's an increased risk of survival also based on this criteria, so we have to be selective with these patients. So the last part here is what can we do in patients who have steatotic liver or donors steatotic liver for a transplantation. Many of us are doing that have failure of primary non-function, and we've lost graft and patient by transplanting these high-risk patients. So there's a risk management, a diet, and maybe there could be some machine perfusion. For time reason, I will not show you the machine perfusion. There's been some publication that have been done a few years ago, which combine diet, the bezafibrate, and exercise in this patient, and see by combining this different strategy here, we could decrease, they could decrease steatosis from a significant way from one to the other one. There's been some study interested in omega-3 fatty acid. This is here a short meta-analysis which seems to indicate that omega-3 fatty acid is indeed protective or can help in curing the steatosis. And I can show you from our program here, this is a patient who was considered for living donor liver transplantation, he had a routine biopsy, and we found here this biopsy which was estimated to be 30 to 40% steatosis with significant macro. So here clearly we reject this patient for living donation, but we gave him omega-3 fatty acid. And here in a quite short period of time, about 3 weeks, we did the biopsy, and you can see that this moderate or mild steatosis disappear, and in 3 patients, in fact, we have used successfully the right lobe for transplantation. Omega-3, I think, is very interesting. It's very strong property, anti-inflammatory, anti-steatotic, may reduce tumor growth, plus other factors here. And if we compare the omega-6 and the omega-3 with all the different pathways and the breakdown product, The omega-6 is pro-inflammation here, with very well-known molecule like thromboxane, while the omega-3 has exactly the opposite effect. And you can see we can shift one to the other one, so there is way here in diet to go on the good or the bad side in terms of this linoleic acid, whether the omega-6 or omega-3. Here's the summary what the omega-6 does. So clearly it's a pro-inflammation, vasoconstriction, while the omega-3 is protective. And here I can show you also going back to the lab here, we have a control group, omega-3, that's the difference of treatment. And when we expose this liver or these mice or rats, rats to ischemia reperfusion injury, there is a significant decrease when we give omega-3. So not only you may change or cure the steatosis or convert macro to microsteatosis, but there is less injury. And as I showed you before in intravitreal microscopy here, if we have here with or without or after reperfusion, it's a dramatic effect in macrosteatosis, no treatment. If you give omega-3, then you seem to protect the sinusoid. And right now we are conducting in Zurich, and love to open that, a randomized controlled trial in liver resection, not in transplantation, using omega-3 before and after surgery to see if we can decrease injury. And we are doing that not only in fatty liver, but any type of liver with some evidence that could be protective for this organ. So in conclusion, hepatic steatosis clearly increased morbidity and mortality. We are using the MRI. We think this is the best test, but we do not stop looking at the biopsy, of course, of this patient. Microsteatosis, I think, and there is new data coming, is irrelevant. I think that has really no impact on outcome. It's also a nice paper that will come out that shows even combination with macro, micro doesn't add anything in this patient, a study from Korea. Macrosteatosis that have up to 30% do well, and basically you use the same criteria for transplant that normal liver, up to 30% macrosteatosis. If you use the bar, this is the score of 18. On the other hand, when you have more than 30%, you may not put this liver in the trash, but you have to select your recipient properly to decrease the risk and to use it. Strategy, we have a few. One may well be omega-3 today is easy to take, and it seems to be protective. I did not have time to show to you, but we have some machine perfusion when we can put the graft before transplantation, and it seemed also to help with this. And I would like to dedicate that also to my team who is working here in the field of HPB surgery, from staff to fellow. We did a lot of this work on steatosis and others, coming from altogether 13 different countries, which is a big satisfaction to have these people around, and I thank you for your attention. Thank you.